Our team and I would like to present our proposal to you entitled Trap Zone. It is the Urban Childhood Asthma Crisis, and it is a study that is a community-based cohort study. In the literature, childhood asthma affects 8.7% of children overall. It is substantially higher in metropolitan areas, making it one of the most common chronic diseases here in the United States. Low-income and minority groups are disproportionately affected by environmental exposures, particularly air pollution from traffic in places like Indianapolis. By taking care of these issues, our team believes that we can lower ER visits, increase student attendance in school, and eventually provide our kids with a healthier future. Research consistently highlights the strong link between traffic-related air pollution, TRAP, and childhood asthma, with urban children facing a 20 to 30% higher risk due to elevated exposure. Living near roadways amplifies this risk. As you can see from this snapshot here, this is the area known as a trap zone in Indianapolis. It's located at I-70 and I-65, and it is so deemed the trap area by the Environmental Health Protection Agency. Asthma remains a significant health challenge for children. Studies reveal that as urbanization rises, children with asthma continue to face a major health burden. Those aged 0 to 17 account for 33.8% of ED visits, as you can see here, and they have a very high mortality rate. Children experience disproportionately higher hospitalization rates with 11.3 inpatient visits per 10,000, compared to 2.6 per 10,000 among white children. Now, asthma is a serious public health issue in Indiana. Nearly 10% of adults are currently diagnosed with it, and children account for a third of all ED visits. Children are disproportionately affected. And this affects where they live, their communities. And unfortunately, there in the Midwest, in this area, there are very few studies that take on this issue, unfortunately. And so the studies that exist are underrepresented at this time. When we think about socioeconomic barriers, we focus on asthma cases. If you look, you can see 40.9% of asthma cases are in households that earn less than $35,000 a year. And 18.9% of these children live in very poor maintained housing. The purpose of our study is to investigate trap exposure and its effect on asthma, the onset and severity of illness in Indiana children ages 5 to 12, quantify risk based on proximity to highways, and measure PM 2.5 levels and nitrogen oxide levels. Evaluate the role of the socioeconomic issues. And so our central question that we ask is, how does elevated exposure to traffic-related air pollution influence the incidence, severity, and frequency of emergency department visits for asthma among Hispanic and non-Hispanic Black children aged 5 to 12? And to what extent does it contribute to and inform the broader scope of health disparities among the population? Our hypothesis is simply this: systemic inequities, including substandard housing conditions and limited healthcare access, contribute to a significantly higher prevalence of asthma, an increase in severity of symptoms, and elevation of emergency department visit rates among Hispanic and non-Hispanic Black children under 18 compared to other multiracial populations. With respect to specific aims, our investigation aims to first quantify the relative risk of asthma among children exposed to high levels of traffic-related air pollution compared to those in lower exposure areas. Second, examine how the duration of trap exposure affects asthma symptom frequency using 2 years of follow-up data from the asthma control test. And lastly, evaluate how socioeconomic factors such as household income, parental education, and housing conditions mediate or modify the link between trap exposure and asthma outcomes. Thank you.
We'll be discussing this project. Our reference population is children aged between 5 and 12 who reside in the most population-loaded neighborhoods of Indianapolis. Areas near major interstates I-70 and I-65, such as the Hogville, Martindale, Redwood, and the near East Side neighborhood are the area we are focused on. The APA has designated this as environmental justice zone because these communities lie near neighborhoods, contain high level of nitrogen, dioxide, and particulate matter, and have a high density of vulnerable population. Thus, the CDC and local Indiana State Department of Health reported that the children in this area are more hospitalized for asthma-related problems. To be eligible, participants will have parents' reports at baseline and by spirometry that the child does not have a clinical asthma diagnosis and live in the zip code for the duration of the study. Additionally, we will obtain information sent before enrollment from parents. This particular urban population allows us to ensure the relevance and impact of the results at environmental health disparity and pediatric respiratory outcome. Indeed, these communities are disproportionately exposed to environmental hazard and lack adequate access to preventive health care, and therefore will be optimal for focused public health intervention when data is available. Our study will enroll 1,200 children, half of whom reside in high trap exposure area. In contrast, the other half live in low trap exposure area. According to Gordis 2014, standard epidemiologic studies design principle dictates a minimum relative risk of 1.5 for asthma incident, and we can detect a sample size large enough to have 80% enroll at time of spirometry at entry to ensure asthma is absent. Administrator parents are surveyed to obtain baseline demographic and environmental exposure and recall for spirometry at 12 months interval and at any time when parents or symptom report indicate a change in asthma status, symptoms of acute illness, or evidence of potential exacerbation. This guarantees that our sampled air is well defined and correctly classified by trap exposure. Using this measure of effectiveness needs strict requirement for cohort design, which will increase interval validity of our finding. The second way that stratified sampling contribute to the generalization of our result is that it makes our finding applicable to broader urban population restricted by similar environmental challenge. For this study, we choose the prospective cohort design as it is the best model to study the effects of traffic-related air pollution on children asthma development over time. This design enables us to track population of children without asthma over 2 years and see whether and when asthma develops. Over the course of the study, we will also be monitoring several outcomes, including new diagnosis of asthma, confined by ICD-10 coding and spirometry, symptom control scores using the ACT, emergency department visit for asthma. By having this outcome measure, we do good job of assessing this disease's burden. Medical record reviews and follow-up survey will also validate health outcomes. Furthermore, it encourages a deeper connection with participants and more subtle data collection. Our study built upon findings from Altman and al. 2023 and Krantz-Wood 2022, both of whom highlight the power of cohort design in elucidating environmental health trends among children. Asthma diagnosis will be medically confirmed using electronic health record and ICD-10 coding system. This will be supplemented by spirometry to assess pulmonary function, particularly the FEV1/FVC ratio. In addition to incidence, we will track asthma symptom control using the Validity Asthma Control Test ACT, administered every 6 months. This tool measures frequency and intensity of symptoms such as coughing, sneezing, and nighttime awakening, offering a standardized way to assess disease burden over time. Environmental exposure to TRAP will be measured using geospatial mapping. This allows us to distinguish between ambient and household level risk factor. By combining objective clinical data, self-reported, and environmental exposure data, we ensure a rich data set that can capture both biological and social determinants of health in our study population. The second part of our data collection scheme is to obtain demographic, socioeconomic, and air quality data to provide a general context for understanding asthma outcome. The daily PM2.5 concentration will be obtained from fixed site air quality monitors operated by the Indiana Department of Environmental Management to assess outdoor air quality. The measurements will be geospatially interpolated to participants addressed using kriging method to produce locally assessed exposure for participants in the cohort. We will examine FEV1 and FEV1/FVC ratio in terms of changing value, which are good indicators of airway obstruction and asthma control. The study will be conducted over 30 months timeline divided into distinct observation phases that all components are implemented with fidelity. In first 3 months, we will finalize our survey tool and protocol, obtain institutional review board approval, and initiate participant recruitment. We plan to work closely with school nurses, parents, teachers, organizations, and local pediatric clinics to ensure high recruitment and constant rates. Between month 4 and 6, we will administer baseline survey and spirometry tests to all enrolled children. We will also begin the GIS mapping of residences and collect initial PM2.5 data from local monitoring stations. Every 6 months, we will revisit family to collect updated ACT scores, confirm any asthma diagnosis through medical record review, and reassess TRAP exposure in the event of a household move. The longitudinal nature of our follow-up allows us to capture both related health outcomes. Finally, during months 28 to 30, we will conduct statistical analysis using SPSS and ARCGS software, applying Cox regression and Poisson modeling to explore our hypothesis. Finding will be disseminated through peer review, journal, and policy briefing tailored for Indiana Department of Health. In this study, our exposure variable of traffic-related air pollution trap will be measured at geospatial environmental data level. The two primary metrics by which trap will be defined are: 1, child reside less than 200 meter proximity to major highway to capture peak exposure. And 2, average PM 2.5 concentration over the past 12 months exceeding 15 meter, as matches up with EPA threshold for unhealthy air. We will geocode participant addresses using DIS software and then calculate their linear distance from interstate road in order to optimize this. Furthermore, daily PM 2.5 data from IDEM will be used, and spatial interpolation will be utilized to generate a continuous pollution surface across Indianapolis neighborhoods. These steps strengthen the reliability of our data, lower the risk of miscalculation biases, which is necessary for all high quality epidemiological cohort study. In this cohort study, our outcomes are focused on 3 key areas: asthma incidence, symptom frequency, and healthcare utilization. The primary outcome is the development of asthma identified through a combination of a physician diagnosis and clinical confirmation using spirometry. Specifically, we will use the IC10 code J45 for asthma and spirometry reading where a forced respiratory volume in 1 second to forced vital capacity ratio is less than 0.70 will be used as an objective marker consistent with epidemiological standard outlined by Coderman and 2015. This dual confirmation strengthen internal validity. Our secondary outcome focus on the symptom frequency and control with which we will measure using the asthma control test ACT. This validates the tool capture the frequency and severity of symptoms such as coughing, sneezing, activity limitation, and nighttime awakening. This information will be collected from medical record and electronic health record. This comprehensive approach allows us to better understand how environmental exposure trap influence both the onset and progress of asthma in urban population.
Thank you, Abala. Next, I'm going to dive into the safeguards that we will have in place for this study. For confidentiality, all personal identifiers will be removed, and we will use data encrypted in secure password-protected servers. For our surveys, this just helps keep everything safe, all data safe. Since our groups are going to have adolescents, we will get informed consent from the guardians of the participants, and throughout the route of the study, each participant and their parent or guardian will be guided through each point and are allowed to opt out anytime they feel necessary, no questions asked. When looking at minimizing risk, only non-invasive procedures like spirometry and surveys are going to be used. And to maintain good data quality, there will be a placement of double entry systems and periodic audits here and there to ensure accuracy. Next, I'm going to be talking about statistical analysis and the primary models that we'll be using. Cox proportional hazards regression will be used to estimate hazard ratios for asthma incidence among the exposure groups. This method allows us to analyze time to event data where the event is incident asthma diagnosis. Cox regression is especially suitable for longitudinal studies like ours, where not all participants may experience the outcome during that study window, that 2-year time. Variables that are noted are age, sex, race, ethnicity, parental smoking, income level, and housing type. For time to event, participants will be eliminated at asthma diagnosis, any loss of follow-up, or just the end of the study. To ensure the robustness of our analysis, we will test the proportional hazards assumption using Schofield's residuals and graphical diagnosis. If any violations are identified, we may stratify the model or include time covariates. Results will be reported as adjusted hazard ratios with 95% confidence intervals. Additionally, the odds ratio and relative risk will be calculated to look at the relationship between asthma incidence and emergency room visits compared to the trap exposure. For symptom analysis, we will use Poison regression. This can track symptoms of an asthma attack and missed school days via ACT data. This model is ideal for analyzing outcomes that are measured repeatedly and may follow a non-normal distribution. All this is investigated and supported by Rodriguez et al. In 2019. For healthcare utilization, we will use logistical regression to estimate the odds of emergency room visits or hospitalizations for asthma across different trap exposure levels. Additionally, we will include interaction terms to assess potential effect modification by key variables such as race, ethnicity, household income, and neighborhoods. This will help us identify whether certain subgroups are disproportionately affected, consistent with the environmental justice literature. This literature is mainly Clark et al., a study done in 2014. These analyses aim to ensure that our conclusions are both scientifically valid and socially meaningful. Like any epidemiological study, our community-based cohort design will have some limitations. One key concern is the loss of follow-up, which is especially relevant in urban and low-income populations where residual mobility is high. To combat this, we'll implement retention strategies such as reminder calls, flexible scheduling, and small incentives to encourage continued participation, strategies that are backed by done by Gordis in 2014. A second limitation is the possibility of unmeasured confounding variables like indoor exposures of mold, dust mites, and secondhand smoke. While we collect data on housing types and parental smoking, we cannot directly measure all of these different variables and indoor pollutants. Acknowledging these limitations and responding proactively strengthens our study's validity and transparency, ensuring that policymakers and healthcare providers can trust and act upon our findings. For further study, we'd recommend conducting a study on the effectiveness of indoor air purifiers compared to asthma incidence by using a randomized trial. Previous studies have shown that these devices can reduce particulate matter and improve lung function, particularly in children with asthma. We also recommend additional studies looking at similar geographics across the Midwest, such as Chicago, Detroit, Cincinnati, to further support this study. These future directions demonstrate our commitment to long-term impact through both science and policy. Some of the instruments and variables that are going to be essential in our study are the Asthma Control Test, or ACT, spirometry, parental surveys, and environmental data. By combining clinical tests, validated surveys, and environmental monitoring, we ensure a comprehensive data set capable of answering our research questions with high precision and scientific credibility. Here is our proposed budget for the study. The estimated budget to perform the study will be about $1.4 million. Similar to the proposed budget that was just shown, this is essential equipment and personnel that will be used throughout our data collection of our study. For equipment, spirometers, laptops, air monitors, and secure data backup systems will be needed. For software, access to SPSS and ArcGIS is required to conduct statistical analysis and for some of our data collection. For personnel, involving epidemiologists, biostatisticians, field nurses, data managers, and a GIS analysis would benefit the study. Here are some funded programs and agencies that work directly with the components of our study, and here are the references. Thank you so much.